Merci.
Comment ça va?
Ça va très bien et vous?
Yes.
Euh, Professeur Germano sera à la 5 déjà là. On va ouvrir l'écran et tout dans 5 minutes.
Il faut que Didier Scamardin, avec lequel vous avez des relations plus privilégiées que moi je peux l'appeler, il n'y a pas de problème, mais que vous prépariez le terrain en disant ce serait bien qu'on soit avec la langue française. Parce qu'il n'y a aucune raison que fasse quelque chose de la langue française pour que Didier Scamardin ne soit pas d'accord.
Ah, c'est bien.
Oui, c'est bien. Ouais.
Bonjour,
Bonjour, Seth.
tout le monde, ça va?
Bonjour. Bonjour, Madame Khti, ça va?
Ça va, vous allez bien?
Ça va, c'est le khadar?
Ça va, alhamdoulilah, ça va bien.
Alhamdoulilah.
Bonjour, c'est Clément.
Bonjour,
Monsieur Sohail, ça va, vous allez bien?
Soir Khair Akhdar, comment vas-tu? On est
Bonjour,
des dinars,
Monsieur Youssef, comment ça va?
Avant?
Bonjour, comment ça va?
Bon après-midi tout le monde.
Bonsoir, c'est Bouzouber.
Bonjour, c'est Youssef, c'est Bou Youssef. Bonjour.
Ça va?
Cyril,
Bonjour, Monsieur Bouzouber.
ouais, bonjour. Ouais.
Bonsoir, Madame Germano.
Bonjour, bonsoir. Pour moi, c'est le jour.
Ah, bien.
Bonsoir.
Isabelle.
Bah, nous aussi, il fait jour, Isabelle, nous aussi. Ça va, il est 4 heures de l'après-midi. Comment tu vas?
Ça va, et toi? Tu
Ça
viens?
va? Ça
Ouais,
va.
ça va. Ouais.
Ça fait longtemps qu'on ne s'est pas parlé. Hein?
C'est ça, mais on s'écrit toujours avec l'email, donc
Ouais.
c'est mieux que rien.
Oui, c'est beaucoup mieux que rien, exactement.
Oui, c'est.
Depuis la dernière fois au Maroc.
Oui, à Tanger.
Pour...
La dernière fois au Maroc, c'était à
Vous
Tanger.
allez bien?
C'est Tanger la dernière fois au Maroc, exactement.
Oui.
Ça va faire bien. Ça fait 1 an, hein, ça va faire 1 an la fin du mois.
Oui.
Oui.
Bonjour, bienvenue tous, bienvenue Madame Germano. Merci d'avoir accepté l'invitation.
Merci à vous.
La partie, Monsieur Clément, Monsieur Bouzou.
Merci pour m'avoir invité. C'est, comme vous savez, je considère le Maroc my second home. J'adore le Maroc.
Thank you very much for that. Sir Khadar, ça va?
Ça va, vous allez bien?
Notre président, Sir Khadar. C'est Sohail.
Bonjour tout le monde. Est-ce que vous m'entendez?
Ça
Bonjour.
va, on t'entend.
Oui, oui.
Bonjour. Bonjour, M. Bouissef.
Je vous
Bonjour,
vois.
Madame Khti. Bonjour.
Bonjour, Abdelmelek.
Sir
Ça va?
Khadar, bonjour.
Je ne vois pas tout le monde.
Tout le monde. Il y a 41 participants. Il reste 2 minutes pour démarrer. Isabelle, je pense, a 2 minutes. Est-ce qu'on peut faire... Souad, je pense, elle va introduire d'abord.
Oui, oui. On a juste un tout petit changement, mais ça sera pour mieux introduire le sujet. Hein, Mouna, c'est ça? On a voilà, on va avoir, avant l'intervention d'Isabelle, un petit cas clinique, mais vraiment pour introduire la problématique de la prise en charge des gliomes malins.
Bon, c'était un petit peu ce que j'avais proposé. Bon, et qui va présenter le cas clinique, c'est Souad?
Non, c'est Dr Mouna Bougrine. Comme ça, on reste aussi dans la thématique de la WFNS Committee. Voilà.
Très bien.
On remercie les femmes pour l'invitation.
C'est gentil, c'est très bien.
C'est ma proposition
Youssef.
à Mouna. Hein.
Et il faut
Oui,
toujours...
ça a été changé ce matin, c'est Bouzouber. Moi-même, j'étais prévenue ce matin par Madame Dadi.
Mais enfin, il faut toujours collaborer, il faut toujours être ensemble. Et donc, je pense que quand il y a une educational activity comme ça, c'est très important qu'il y a 2 comités qui travaillent main dans la main. Et en plus, c'est très bien qu'on peut travailler avec la société du Maroc.
Marocaine, exactement. I think Isabelle and our colleagues, we have Noor El Huda Maria. I guess you are from Bangladesh, yes?
No, I'm from Pakistan.
Pakistan, yes, yes. You were supposed to be, yes, you were supposed to be with us in Beijing, but you have some problems of visa. Yes.
Exactly.
Yes.
Ma'am, first I was supposed to attend your meeting in Tangiers, but then I had some problem in visa because the Qatar Airlines.
But with webinars, there's no problem of visa. It's easier.
Thank you, ma'am. And unfortunately, I couldn't make it to WFNS 2019, where I won the first prize for the WINS ACNS.
Yes, I remember that. Yes, yeah, we have given the prize to Anila Derbar and Sharon Kalista for you.
Yes, ma'am. Thank you so much. I missed the moment. I missed the moment.
Hi.
Hi,
Bonjour, Madame
How are you?
Oh, it's great. I'm sorry, but I have some problem with my laptop because I am not in the house. So yes, I have some problem to connect by my laptop. So I am connecting by my phone. Are you still? No, I know that you hear me, but you know you are seeing.
We are seeing you.
Yes, I am not in my house.
Okay.
Sorry.
Hi, Naja.
Great pleasure to see you. Hi, Isabelle. It's wonderful to see you, and you look great.
Thank you.
Thank you. Thank you for accepting our invitation, Isabelle. And we are very, very happy and delighted to have you among us today in this webinar.
Thank you. Likewise. Moi aussi, moi je suis vraiment très heureuse d'être entre nous avec les amis.
Entre nous, on peut parler français.
Oui.
Isabelle parle tellement bien le français qu'on va lui demander de présenter en français.
En tout cas, salut Youssef. Merci d'avoir accepté bien sûr d'animer ce webinaire en tant que membre de ce comité. Et puis, on a essayé de suivre un petit peu. Là, les gens ne sont pas rejoints encore. Hein. J'espère que je ne suis pas en train d'avoir accepté sur les directives un peu de la Fédération mondiale d'essayer parce qu'un peu les webinaires, il y a un de nos collègues, de nos maîtres qui avait dit il n'y a pas longtemps sur un des webinaires, et je le cite et à qui je rends hommage, c'est professeur Wolzès, c'est un tsunami de webinaires. J'ai adoré l'expression. Et effectivement, je pense qu'il y a une coordination, elle était quand même nécessaire pour qu'on puisse avoir, parce que sinon après on a finalement, c'est vrai qu'on se voit de plus en plus, c'est un plaisir certes, mais en même temps ça nous coince tous les week-ends sur nos chaises sur nos bureaux at home quoi. Donc merci encore. Voilà, on est en off.
Oui, alors
oui.
On peut y aller. Bonjour professeur Al-Khamlichi, comment allez-vous? C'est un plaisir. À chaque fois que vous êtes là, c'est vraiment un plaisir, monsieur Al-Khamlichi.
Ah oui, c'est...
Tu les mutes, il faut enlever les mute.
Il faut oui. Alors, attendez 2 secondes. Mouna, bonjour.
Parce qu'il parle, mais il ne peut pas l'entendre.
D'accord. Rebonjour Mouna. Est-ce que Fahd est là? Je ne le vois pas.
Oui, il est là.
Oui.
Alors,
il est là.
je lui dis...
Ça y est, il est là, monsieur Al-Khamlichi.
Maintenant, on peut l'entendre. Oui.
Est-ce que Fahd est là? Fahd ne m'entend pas. Qu'est-ce qui se passe?
Oui, madame.
Ah, bah bonsoir.
Bonsoir, madame.
Oh, bah, écoute,
il n'y a pas de Caraïbes aujourd'hui, c'est des bouquins derrière moi.
Ah, je vois, mais tu aurais dû nous mettre quand même avec... on est en début d'été et tu aurais dû nous mettre quand même, nous faire rêver un petit peu. Hein.
Tout de suite.
Non, tu fais ce que tu veux, mais je suis en train de te présenter, voyons. Parce qu'on n'est pas encore en live, en direct par rapport aux gens. Ah, c'est une belle photo, en fait.
Voilà.
Un petit peu rêvé dans nos... D'autant plus que je dis à nos invités et nos collaborateurs que finalement, je ne sais pas si mes collègues et nos maîtres marocains on vient d'annoncer qu'on va être encore confinés pour 15 jours supplémentaires.
Non.
Ouais. officiellement il y a un petit moment là.
Non.
Oh, Mouna, ne t'en fais pas, tu vais pas continuer. Hein.
Si, même.
Je remets les bouquins là.
Non, raison supplémentaire pour laisser l'image derrière toi. Alors écoutez, c'est un plaisir de vous voir tous. Et donc je me mets en mute. Hein. Salut Kherdine, c'est toujours un plaisir de vous voir. Alors,
on commence avec la présentation du cas, c'est ça, Swad?
Oui, mais je pense que M. Nakhdar va dire un petit mot pour introduire le webinaire et puis je prendrai la parole pour introduire.
Juste un mot de bienvenue, oui. Well, thank you. Hello, everybody. We thank very much Professor Isabelle Germano for having accepted to animate this conference, this lecture about the current management of glioblastoma. We also thank our colleagues from Algeria, Professor Souad Bakhti and Souhail Sleiba, and our colleague Dr. Bouzouba for the animation of this session. And also Dr. Bougrin and Fahd Daqawi for the technical support, Dr. Bougrin for the coordination and for presentation. And thank you for all the attendance of this webinar. It's to you now, Professor Bakhti or Professor Bouzouba. Okay.
Thank you.
We can start, I think.
Again, thank you to the Moroccan Society for having organized this webinar in conjunction with two committees of WFNS, and this is a new experience and of course a very good initiative. And thank you to Isabelle for accepting this invitation. And I just want to make all of us here knows Professor Germano, but I just want to introduce her. Professor Germani is professor in neurosurgery, neurology, and oncology at Mount Sinai Icahn School of Medicine. She is director of the Comprehensive Brain Tumor Program and co-director of the Radiosurgery Program. She is also a pioneer in image-guided neurosurgery with practical clinics. And her laboratory research focuses mainly on brain tumors, translational research, with particular interest in gene therapy, stem cell, and pluripotent stem cell. She is author of over 20 peer-reviewed and other publications, including 5 books. And also she teach very interesting topics, which is healthcare economics and strategy at the NWU Stern School Business. And I want to say also that recently she wrote with her daughter and a colleague neurosurgeon a very nice little book for girls who are dreaming to be neurosurgeon, and we have had as a member of the WIN WFNS committee the privilege to make a translation. This little book has been translated in 10 languages, and really it will be a great tool in education, particularly for young girls. And I want to say also welcome to my colleagues from the Education Committee, Professor Bouzouba from Casablanca, who is very involved in education, as everybody of us know, and also Professor Sleiba from Algeria. He's the Dean of the University of Béjaïa, and he's also very involved in education. And I know that they are doing a very big job with Isabelle in the Education Committee. So thank you to all of you. And Mouna will begin with a short case clinic to introduce the conference of Professor Germani about management of high-grade glioma. Thank you to you all.
Thank you, Professor Berti. Oui, je partage. C'est bon, vous voyez?
Oui.
Alors, thank you. Je vais mettre pardon. So, thank you, Professor Berti. This presentation will emphasize all the problems we can have with such pathologies. It's the case of a 68-year-old patient admitted in emergency for persistent somnolence and left hemiparesis. He has a history of diabetes type 2, but the beginning of the history of his pathology was on September 2018, where he had a seizure, and then he did an MRI. And the MRI shows this small hypersignal, and it was taken as a stroke and treated as a stroke. But in April 2019, he has a status epilepticus, and then an MRI, we redo an MRI, and the MRI showed this heterogeneous tumor, frontal tumor, pre-Rolandic one, evocating clearly a high-grade glioma. So he was operated with a gross total removal, like we can see in the post-operative CT scan, and the pathology was in favor of an ependymoma, grade 3 ependymoma. The patient had radiotherapy and chemotherapy, and in July 2019, he has a CT scan, a controlled CT scan with this cystic image, frontal cystic image. After this CT scan, he underwent stereotactic radiotherapy, and he was followed up in the consultation, neurosurgical consultation. The MRI of November 2019 showed this cystic image with the appearance of edema that was interpreted as a radionecrosis. So we just followed him, and he was starting to have hemiparesis, left hemiparesis, and starting to install a frontal syndrome. In May, the 25th May, 26th May 2020, he came in emergency with a Glasgow Coma Scale 13 and his hemiparesis. And in the CT scan, the MRI, we have this cystic tumor, but with this huge edema. We asked ourselves if it doesn't reoccur. So the patient was admitted. He was corticosteroids. He improved since the day after. He's now GSS Glasgow Coma Scale 15 with his hemiparesis and frontal syndrome. And the MRI done 2 days ago shows it is clearly recurrence of his tumor. And the question we are asking here is, what more can we do? What more can we do that we didn't do before? I ask this question to Professor Germano, of course, and to all the attendees of the webinar. And thank you for attention. If you want me to repass the images, I can.
Thank you, Mona.
Thank you.
What do you think, Isabelle? I think you can make your presentation and answer after about that.
It's up to you. Sure, we can keep this case in mind. I can do my presentation and then discuss the presentation and the case. Is that a good idea?
Yeah, it's the purpose of this presentation of this case. I think, as I said to Sued, she's of course the moderator. Maybe it's starting your conference with this. The big problem is that what we can do in this when there are recurrences. Thank you.
I think it's better to begin to start with the conference and discussion.
Okay.
Okay, so I am ready to share, but I need Muna to stop sharing.
I will stop sharing. Okay.
Okay, and now that you stop sharing, I can share mine. Screen, okay. Okay, can you see my screen?
Yes.
Excellent. Okay, good. So good morning. This was a great case to start the morning. And I was asked to talk about current management of high-grade gliomas, which is a topic that is very dear to my heart since I am a brain tumor surgeon and I've been practicing as one for many years. Shukran to Professor Lakhdar, Professor Labadi for preparing this fantastic seminar. And naturally, as we were saying, entre nous, before we started, this is a combined effort of the WFNS Education and Training Committee and WIN Committee. So thank you, Professor Bakhti, Chair of WINS, and thank you, Professor Bousaba and Tliba, who are incredibly hardworking and active members of the Education Committee to be here today. And goes without saying that the coordinators of this meeting, Muna and Fad, have done a great job. So thank you guys for getting us all together. It's not as nice as being in Tangier, I have to admit. However, this is better than nothing. And it's nice to be among friends. So just a few words about primary brain tumors. The real incidence can be determined looking at a central brain tumor registry. And there are quite a few of those. The data that I'm showing you now is the one that we have in the US. And it's interesting to remark that primary brain tumors are among the top 10 causes of cancer death, cancer-related death in the United States. So if you look at this graph, in fact, brain tumors are among the top 10 causes of death, period. You see that major cardiovascular diseases is all the way #1, and then lung cancer, diseases of the respiratory system, prostate for men only, colon and rectum, breast, pancreas, and then brain tumors. So it is a disease that is important to understand, and that is primary brain tumor is a disease that is important to understand, and it's important to see what can we do as neurosurgeon to help the disease. In this graph here, you can see the distribution with the relationship to the age of the brain tumors, and all the way up on top, there is the glioblastoma right here. Those little squares are the glioblastoma, and glioblastoma is one of the most common primary brain tumors. And the reasons are unknown, but clearly glioblastoma is part of what we consider high-grade gliomas. So just in terms of a definition, high-grade gliomas are made of the glioblastoma, the anaplastic oligodendroglioma, and anaplastic astrocytoma, and then anaplastic ependymoma. So those are what we consider by and large high-grade gliomas. Sorry, I don't know what happened. Okay, and so as I said, I think that it is important to understand the disease. There are many more new tumors that are diagnosed every year, and approximately 1/3 of the primary brain tumors are this big family that we call AGG, high-grade gliomas. These are, by definition, very aggressive tumors because they are infiltrative and they do not have boundary with the surrounding parenchyma. And what we're humbled by is the limited therapeutic efficacy that we have at the present time. Clearly, radiation and chemotherapy, in addition to surgery, are all tools that are used, but in spite of that, the longevity or the life expectancy for a patient with glioblastoma remains limited. So I'd like to present this topic looking at what is the economic burden of the brain tumor disease. And in the way of a definition, economics is the study of how society uses its limited resources. And resources are limited no matter where you are. And I think that this recent pandemic made us understand that we're all vulnerable and there is no such a thing as unlimited resources. So my talk is going to be divided into three burden that I consider very important. One is limit the number of deaths secondary to high-grade glioma, the neurological disability of the disease, and the treatment cost. And so for deaths, can we cure a patient with a high-grade glioma? And the answer is yes. Gross total resection of a glioma occasionally, rarely, but can result in a cure. And naturally, now we know that for metastatic disease, that is more the case. What about neurologic disability? There are two things that we as neurosurgeons can do: restore neurological function and avoid new neurological deficits. And I will touch upon both. And then how can we decrease the economic burden by looking at the treatment cost? I think that just throwing generic random treatments at patients will increase our society cost, and we should really limit that and become more patient-specific oriented. So what about us as neurosurgeons? We all love to operate, and is it really correct that by performing an aggressive surgery, we can improve the outcome in newly diagnosed patients with glioblastoma? And the answer is yes. The data started to pile up at the beginning of 2000. This is a paper from 2008. And you can see the difference in outcome in patients that were operated on with a resection that was suboptimal, and those that instead had a gross total resection, with the light curve here showing that there is a significant improve in longevity. And here is a nice paper that was published a couple of years ago, again, looking at the literature this time and showing that the patient that underwent a gross total resection have, and this is the dark line this time, have a significant improved survival. So yes, as neurosurgeons, we can have an impact on survival for these patients. Now, one of the challenges of primary brain tumors, high-grade glioma, is that when we look at them, not necessarily, the diagnosis might not necessarily be straightforward. And the case that was presented prior to the talk is a very good example, right? So that diagnosis was not that obvious to start with. And even if in a case like this one that I'm showing you now, the diagnosis is a little bit more obvious, there is always the challenge of understanding where that tumor is within the brain. This is a 65-year-old, so not very different than what the case that was presented in age. And this case also presents with seizures, because the seizure presentation is approximately 1/3 of patients with primary brain tumors, high-grade gliomas, that present with seizure. And this patient has a chest, abdomen, and pelvis CAT scan showing that there is no cancer in the body. So it is most likely that this is going to be a high-grade glioma. And so what are we going to do with this tumor? Do we want to do a biopsy? Do we want to resect? And throughout my career, I changed my approach to these tumors. I think it's much safer to resect these tumors for two reasons. Number one, because it will decrease the burden of the disease. See that this patient has issues, not just because of the tumor, but because of the surrounding edema. And so by removing the tumor, we most likely will be able to have that edema decrease, and therefore the patient can tolerate the adjuvant treatment, and that is radiation and chemotherapy much better. And second reason why I think a gross total resection is preferable, it is because the tissue diagnosis will be much more accurate. And finally, we know that if we can give a gross total resection to this patient, the patient will have improved survival. So where is this tumor located? This tumor is located in the temporal lobe, and it's very lucky that it is right at the bottom of a very large sulcus. So what that means is that we can perform a minimally invasive surgery and dissect the sulcus and find the tumor at the bottom. So this is the surface of the brain, and clearly I cannot see, I have no visual clue to know where that tumor is. The reason why I know that I'm on it is because I am looking at my forceps tip, and then I can see the registration showing me on the MRI that I'm on the correct sulcus. So I do a transsulcal resection. I go in, I resect the tumor. You can see that the cortex of the brain was never touched, right? And this was just done through the transsulcal resection so that there is no invasion of the cortex and hopefully no deficit. And so what we have shown with this technique is that we can decrease the length of stay, LOS, we decrease the neurological deficit, and subsequently other studies, multi-center studies, show that you also decrease the incidence of leptomeningeal disease because you have done a gross total resection. What does it take to do that? I don't think I could do this without image guidance. And I think it's important to recognize that this is a technology that has been going on for a while. In the US, I was the first user of the optical digitizer, and I started using that in 1993. And as you can see, this technology was embraced and endorsed by the neurosurgical community, not just in our country, but I think pretty much everywhere. There are multiple different units that are available that are all pretty much the same. It is important to remember that this is just one tool that we have in the operating room, and we still need to exercise our own understanding of the anatomy, because if we only rely on the tool, we can get in significant trouble. And why is that? Because brain shift does happen. And here's a beautiful picture that was published many years ago showing the microscope focusing on a very small little artery here. And you can see that just by staring at it, nothing has been done here. There is no tumor resection, nothing, just the dura is open. And you can see that the image go out of focus within several minutes. What does that mean? Is that the brain has been shifting. Just by opening up the dura, there is some shift that occurred. And then we and others published that when the tumor is greater than 30 cc's, and if you're close to the ventricle and if there is CSF that is drained, clearly that shift will occur. And so this is why it's important to always keep that in mind and exercise our understanding of the anatomy. So how can we prevent being misled by the image guidance? There are multiple things that we can do, like not enter the ventricular system, not administer mannitol, some of the positioning and so on and so forth. And those are all described in the literature. However, even with that, intraoperative shift can occur. And therefore, we have to re-update our images, either through the use of ultrasonography, or if you have it, through an MR, intraoperative MR. We at Mount Sinai do not have one. So, don't feel like, if you don't have it, you cannot function as a brain surgeon. I've been practicing at Mount Sinai since 1993. I never had an intraoperative MRI. So here is the ultrasound that we interfaced. These are a historical picture. You can recognize the equipment from 1995, but now it's fancier, but it's still the same ultrasound probe, and it's still connected with one of the navigation systems that you have. There are tumors like brain metastases, like glioblastoma, that are very, very echogenic. And so when you put the ultrasound probe on the brain and you co-register it with the MRI, and this is all already inside of your navigation system, you might need to upgrade it with a particular software, but it's nowadays very, very inexpensive. So you can see that the metastatic disease and the glioblastoma have a very high echogeneity, and therefore you can recognize the tumor within the brain with the ultrasound probe. You can re-register, and then at the end of the resection, you can scan the brain again, and you can see that there is lack of echogeneity. So you perform an intraoperative confirmation, which does not mean that you don't need your postoperative, but what it means is that if you see that there is a residual, you can continue on with the surgery. The other way that is relatively inexpensive to really see better what is necessary to remove is the use of 5-ALA. In Japan and Europe and probably Morocco as well. You've been using it for many decades. For us, it's novel because it was just FDA approved a couple of years ago. The way in which it works is that it is part of the heme biosynthetic pathway in all mammalian cells, and it is transformed by the mitochondria in protoporphyrin 9, PP9. And when it's transformed into a protoporphyrin, it becomes fluorescent. And so in normal cells, the PP9 is chelated by a ferrochelatase into the heme. And there is a decreased level of ferrochelatase in tumor cells. And therefore, the tumor cell will be more fluorescent than the normal brain. So this is the main difference between performing fluorescence-guided surgery with 5-ALA versus other fluorescent agents such as ICG, isofluorescein, the yellow one, because those are based on the leakage through the blood-brain barrier and not on the activity of the cellular tumor cell. Here is the 5-aminolevulinic acid. This is how it is then the intratumoral synthesis is transforming it into a PP9. And here you can see that on the wavelength of 440 nanometers, it becomes fluorescent. Here you can see an intraoperative picture. This is where the tumor is. And when we switch from the white light to the blue light, we can see its fluorescence. This is how it's given, and the purpose of our study was clearly very crude, was just to make sure that there was a histopathological correlation. And what we found, like many other studies before found, is that there is a very good correlation between fluorescence and tumor cell, up to 97%. So I hope I convince you that doing a gross cell resection is something that we as neurosurgeons can do. We have many tools. We have to use them judiciously, but they're there. And now I would like to look into the concept of neurological disability, restore the neurological function and or avoid the new neurological deficits. Why is that important? It's very important because quality of life in high-grade glioma is quintessential. There are many evidence-based papers, and I have on the screen one from Pakistan, showing that the role of extent of resection and quality of life in patients with newly diagnosed glioblastoma has an impact on overall survival, and has been shown over and over again that if you remove that quality of life, even if the patients had a gross cell resection, they live less long. Okay, and that is self-intuitive, because I think that part of being alive is being happy. And if you're not happy, you might not want to live that life. So quality of life and neurological deficit. Why is it important to understand exactly what we're doing prior to going in? Because in the brain, most of the brain is eloquent. Eloquent cortex, by definition, is a part of the brain for which another structure cannot take up function, even in the event of an injury. And this is a concept that we need to remember when working in the brain, not just for brain tumors, but also for epilepsy and AVMs. And so here is a 55-year-old right-handed woman that is presenting with left upper extremity weakness and difficulty speaking. I'm afraid that this is actually on the slide is incorrect. Pardon me. This is a right upper extremity weakness, and her tumor is on the left side. Sorry about the typo. In any event, you can see the patient right here. The patient is before surgery, has this wrapping because we put some markers on. This is a right arm. And as I'm playing this movie here, you can see that I'm asking her to straighten up the fingers, and she's not able to because she has this paresis. She's not able to retrieve the words. You see the weakness of the right hand. And you can see that she is having a significant amount of difficulty retrieving the words and articulating those words. So why is that? The reason why this is happening is because when we look at the anatomy of this tumor, is sandwiched between Broca's area right here in the frontal operculum and the motor strip that is mapping for phonation muscles. So here is pentile homunculus. And so if you take this picture and you look at this right over here, you recognize the sylvian fissure here that is pushed down by the amount of swelling. And you can see that although the tumor is not in the phonation muscle, but phonation muscles are right here, but it is, the edema is pressing on them, hence the deficit. So this tumor is giving her trouble by mass effect edema as opposed to really destruction of the fibers. And that is very important to understand, because now that we have this in-depth understanding of the anatomy, we can tell this patient that most likely with an operation, her neurological deficit will improve. We can also let her know that most likely we can perform a gross total resection of this tumor without inducing any new deficit. And why I'm saying that? It's because this tumor, if you measure it, this is the sylvian fissure, and if you go up, it's just around the 4.5 centimeter mark. And we know that up to 4.5 centimeter mark, there is no motor function, because the hand, the thumb starts around 5, and the phonation muscles and or facial expression muscle are bilaterally represented. And so even if you injure that cortex, there is the other side of the brain that will be able to kick in. So this is very important information that you as surgeon need to gain prior to surgery, to perform the surgery and to counsel that patient. And here's a cartoon to describe what I just said, that in cases where the tumor grows very rapidly, like a glioblastoma or a metastatic tumor, the white matter fibers are not destructed, that are not infiltrated, but they are pushed against and by the tumor directly, and or the edema is deforming those white matter fibers. Very favorable situation. We can obtain nice pictures like diffuse tensor images, tractography. I love those pictures. They always bring some color into the operating room. Just remember that you really need to know what your team is doing. And when I say team, is the neuroradiology and the medical physicists are doing at your institution. It's a great paper from Sonia Pujol in 2014, showing that 10 different institutions in the United States represented the corticospinal tract in 10 different ways. So you can imagine if you use this picture here for guidance, or this picture here, you have totally different information. So just be sure that when you start using the DTIs, that you know how they are represented in your own institution. And so here are the intraoperative pictures. You see that the brain is swollen here. I put an subdural strip to monitor. The reason why I do that is because I like to do SSCP to confirm where the central sulcus is, and so that I know where my landmarks are. I also do a little bit of EKG to see if there are epileptiform discharges, not to go and chase after those, but those can be helpful subsequently if the seizure issue is not resolved. This is the preoperative MRI. This is the postoperative MRI showing a gross total resection of the lesion. This is the patient in the office. And as you can see, she is now able to hold my fingers, whereas before she was not. She's also able to talk. very, and you don't hear the voice, but I can tell you that she said, Dr. Germano took out the tumor out of my brain. And this is 7 days after the surgery. Most of my patients go home after 2 days, 48 hours after the surgery. I don't shave the hair because there are multiple studies showing that actually the rate of infection possibly is even lower if you don't shave. So I think that for her, although the diagnosis is that of a glioblastoma, her quality of life is maintained. I put that picture up just to show you that it's very important for the third part of this talk, which is how can we have patient-specific treatment to remove these tumors in big pieces so that we can have the opportunity to analyze the molecular signature and really come up with a good therapeutic option for each patient. So it is very important to send ample tissue to the neuropathologist. Otherwise, the diagnosis might not be straightforward and sometimes might be misleading. I mentioned that I use intraoperative monitoring with SSCP. I really like this technique. It is very inexpensive. It's done with a subdural strip. As you saw, the concept is that there is inverted phase reversal that I'm looking for to go between the motor and cortical strip. And so for me, it's just a confirmation that my interpretation of the preoperative images is correct. It does require a neurophysiologist with you and or a technician that is monitoring with you. But again, in the great scale of things, it's not an expensive technique to have. So I think that we need to always keep in mind that we want to do good to the patient, right? And we also need to preserve the function. So this was spoken by Hippocrates, askein peri ta nosomata duo, ophelaien I meblatein, and I translated in French, avoir dans les maladies deux choses en vue, être utile, au moins, ou du moins ne pas nuire. And I'm sure that there is an Arabic translation. I'm going to ask my friends to provide it for me, and I will rehearse for my next lecture. But I really like this sentence because I think that it's very important that we remember that we want to do good. We really want to help our patients. And so then the question is, when is it necessary to do brain mapping? What is brain mapping? Do we really need to perform brain mapping in every case? And my answer is yes, but there are different types of brain mapping that one can do. And it is very important not to just use, one size fits all and use an incredible amount of resources if it's not necessary. So my goals, my questions are, when is brain mapping needed? I think we always need brain mapping, but some of this can be done preoperatively. What are the techniques that are available? And how should the information be used? And then always remember that unfortunately, no matter how sophisticated are our techniques, there are always pitfalls. So the cheapest way, the best way is to look at your 3D, three-planar images prior to the surgery. I like to look at them not just in axial, sagittal, coronal, but also in the way in which the instrument is held, which in some navigators are called trajectory view 1 or 2, and then if possible to reconstruct it as a three-dimensional object so we can do some practice with the resident. Again, nothing really new, but this is a paper that sometimes people forget to review. And this is showing that there is central sulcus on the part where the tumor is. There is a tumor that seems to be relatively well circumscribed. This is the motor cortex. Clearly, this tumor does not involve the motor cortex. There is no question. So there is no reason here to keep this patient awake. But there is some need to do intraoperative mapping to confirm the SSCP would be my choice because it's the fastest and least expensive. You can also do direct cortical stimulation. Totally different from this case, right? This case clearly is a very infiltrative tumor, and for sure it is in the motor cortex. So here, probably a more in-depth intraoperative awake procedure or asleep is necessary. So again, we live in a world that is with limited resources. We always need to assess the cost and benefit analysis. And for me, for neuro-oncology, I think that I look at the onset of the tumors, acute versus chronic. In other words, is the patient, the first presentation has been tumor sitting there for a while, because clearly if the tumor has been there for a while, like the one that you showed, at least 2 years, this is not going to be it's unlikely that this is going to be a de novo glioblastoma. Most likely it is a glioblastoma that progressed, and or in your case, your diagnosis was anaplastic ependymoma. But in any event, it is a tumor that progresses from a low grade to a higher grade. And clearly there is always a difference between the fact that the tumor is infiltrated versus a demarcated tumor that is much easier to then assess. So preoperatively, brain mapping can be done by looking at very sophisticated images. At the beginning of the 2000s, there are more that we're able to tell us where the language syntactic processing is, where the music and the rhythmic motion and so on and so forth. And all these are much more advanced now, 20 years later. However, there is one thing that we need to remember is that nous sommes tous unique. And therefore, because we're all unique, for each of us, although the MRI shows something, it doesn't necessarily mean that the interpretation of those pictures will be 100% overlappable intraoperatively. So let's look at this case of an oligodendroglioma. This is a patient that had a biopsy at another institution, is slightly at the periphery of the tumor. She was given the diagnosis of oligodendroglioma. At that time, the tumor was very well circumscribed, and then she presented to us with a new enhancing lesion, and now you can see that some of that tumor might not be as circumscribed as before. So clearly this is a patient that would benefit from a functional MRI. This is how the patient is tapping the fingers just to be sure that the technique is working. And then here is the tumor, and you see that we're clearly far away from the motor cortex, which we knew, but now when we do the counting is clear that the technique is working, and we see that the tumor is surrounded by speech function. So for this particular case, the functional MRI is helpful to confirm that we are within BRCA. Functional MRI works on the bold effect, as you can read on the slide. And so the question for brain tumor is, could impaired autoregulation near brain tumor make it inaccurate? And the answer is yes, it does. And once again, it really depends on how the images are analyzed, and each of us has to gain the experience base of what that analysis is. In the literature, the concordance between functional MRI and intraoperative cortical stimulation ranges between 61 and 100%. So the big range, and the accuracy is between 5 and 15 millimeters. So in this particular case, I think that it is important for me to do an awake mapping procedure. The way in which I like to start is with a laryngeal mask, and then the patient is, the laryngeal mask is removed during the surgery. I do the intraoperative cortical stimulation to induce speech arrest. I'm afraid these videos don't work, but in any event, when I induce the speech arrest, because I am in the perimeter of the tumor, I repeat it 3 times, and then I proceed with the resection of large specimens so that the diagnosis can be accurate, not just the histological diagnosis, but really the genetic molecular signature of this tumor. And here's the postoperative MRI showing gross total resection. And here is the patient after the surgery. Again, the video is not that important, but what it is important is that she's speaking up a storm. She has not lost the function of speaking. In her case, was an anaplastic oligodendroglioma, so very important to have all the molecular signatures so we could really target her therapy. A few slides on what direct cortical stimulation is all about. You saw me using in that case. This is how I use it. I drive the current all the way up to induce those after discharges. And then I use a current that is right below the after discharges. Important to remember that no paralytic agents have to be used by anesthesia. The advantage is that you can have a very detailed mapping of the cortex and the white matter. You can also, but you need to do intraoperative EKG so that you can detect those seizures. You need to be sure that you can watch the arms. The best way to extinguish the after discharges, if you see them, is with cold saline. So always keep it on the operating room table when you do direct cortical stimulation. The advantage is that it does identify electrical language. However, it could cause electrical spread. So this is one of the pitfalls. And so what that means is that if you're stimulating over here, and if you use a current that it is above the after discharge threshold, you will unfortunately cross with those U fiber tracts, and in essence, stimulating the sulcus or the gyrus that is ahead of you or behind you. And so you have a false information, which is really detrimental. So it's very important to get very accustomed to this technique before you use it for guidance, for real guidance. And then naturally the opening have to be big because you need to expose the eloquent cortex if you need to map it. So in the way of understanding or what I plan to do prior to the surgery, I try for those cases where it's necessary to acquire more information on the anatomical configuration. And then it's only really a handful of cases that will require functional determination within the surgery. And instead, I think is a very big number of cases that will necessitate to be sure that the tumor is resected intraoperatively with one of those techniques that I showed you. So important to keep in mind that if you have it all, you don't need to use it all for every single patient. It's always good to use common sense, and it's always good to understand what are we trying to accomplish. And if you feel that one of these long list of things that is on the slide is not going to benefit your patient, you shouldn't really do it just because someone else is doing it. Now, quality of life is not just not inducing a new deficit or preventing the patient from having one, but it's also related to seizures, as we saw in the case that was presented at the beginning of this, and the one that I presented to you, or the two that I presented to you. Seizure is a very common factor, and by performing surgery, the extent of gross tumoral resection is also associated with an improved seizure outcome. And so this is good to know. You do not need to follow, to chase those epileptiform discharges. Is a good idea to record them so that you know in case you need to do a second surgery. But otherwise, in the vast majority of these patients, if you resect a tumor, you also have a positive impact on the seizures. And finally, just to be on time here, the treatment cost, right? So if we just do generic radiation and quote unquote chemotherapy, are we really solving the problem? And the answer is no. Unfortunately, we do not solve the problem. This is why resecting large specimens is so important. Here is a patient that presented with this deeply seated tumor, differently from what I learned from my mentors during my residency. I did change totally my approach to this tumor, and the reason why I was able to do so is because we were able to develop intraoperative guidance. So you can see that for a tumor of that size, I still keep my craniotomy very small. I use the ultrasonic aspirator to develop a tunnel, and then I really take out large specimens to help our neuropathologists making the correct diagnosis. And here you see again the principle of taking a large tumor through a very, very small opening. And what that does, I don't know what those green lights are, but that's okay. You can see here that there is the tumor preoperatively, and 24 hours after surgery, tumor is resected, and the patient is doing super well, which is really the only thing that matters on these cases. So why is it important? I have this little green thing that appeared. I don't know if can be removed, but I apologize. I don't know where it's coming from. So the reason why it's so important to have a good specimen, large, it is because nowadays, not just the histology of the tumor is important, but also the molecular signature. So when I trained, we were all told that if you see this fried egg appearance, well, that is an oligodendroglioma. And now we know that that is not really the case, because you can call it an oligodendroglioma also if you see some features like 1p19q deletion and or some of the other DIDH mutation and so on and so forth. So we clearly know that just the appearance of the tumor is not sufficient anymore to guide the correct treatment. It is important to recognize that there are multiple sites within the tumor cell that we can attack. And so the signature of the tumor is quintessential. So for instance, it would be totally meaningless to use a TKI, thymidine kinase inhibitor in a brain metastasis where there is no such a thing as marking. And for primary brain tumors, we know that some of the other markers are important that are being investigated. The other challenging issue about treatment is that there are three theories. We summarize them here in this cartoon. 3 theories of why brain tumors do occur. Most likely all 3 are coexisting. There is also a very important impact of the environment. But clearly, if we only develop therapeutic options that are against the tumor cells and we forget about the stem cells, the stem cell will continue to proliferate and the tumor is going to continue to come back. And now we know that there are stem cells in the brain as well, and therefore very likely there are glioma stem cells. And the last little word is about stereotactic radiosurgery that we use aggressively and significantly for patients with metastatic disease for both the brain and the spine. Is there a role for stereotactic radiosurgery for high-grade glioma? This is just to remind us that LINAC and gamma knife can both be used and there is really no difference in the technique. There is a difference in the technique because one is based on gamma radiation and the other one is photon radiation, but there is no difference in the outcome. What is important for high-grade glioma is that it's rarely needed, but it could be used. We published on that. And there is also something new that we are learning from the melanoma community, and that is that possibly radiosurgery could help with the abscopal effect. And since I'm running out of time, I'll just let you read this slide. So in conclusion, I love to be a brain tumor surgeon. I am very challenged, and also I think it's a great opportunity to take patients to take care of patients with high-grade glioma. I think that there are 3 big challenges. Is that in brain tumor surgery, very often what you see is not what you get. Very often for brain tumor surgery is what we think is the truth today will not be the truth tomorrow. And finally is that we love our scalpels because we are surgeons, but we have to keep an open mind that perhaps not just with the scalpels, we are going to be able to take care of our patients. After the scalpel, it's always necessary to have a multidisciplinary approach and to all contribute to the care. And here is something that we completed recently. And I would like to thank Professor Labadi and Professor Bhakti for providing the translations in Arabic and in French. And I hope that we can convey to all children of the world that being a neurosurgeon is a privilege and that we love being neurosurgeons. Thank you for your attention.
Thank you.
Hey, Suad?
Madame Berti. Madame Berti.
Yes, please.
Thank you, Isabelle, for this outstanding presentation about high-grade glioma. And without, comment on va dire, sans tarder, I will call my friends. Huh? I will call my friends Bouzouba and Kliba pour animer le débat. Voilà.
On peut faire le débat en français, c'est plus facile, hein? C'est peut-être mieux.
Comme tu veux.
Oui, pour moi, ça va très bien.
Thank you, Isabelle.
Hi.
Comme vous voulez, Isabelle, si vous voulez qu'on parle en français, effectivement, il y a beaucoup de personnes qui assistent et qui seront peut-être mieux à l'aise en parlant en français. Mais c'est à vous, hein, ça vous revient.
Oui, pour moi, ça va. J'aime bien parler français, donc c'est un plaisir.
Et nous, on aimerait bien parler anglais.
Non,
on aimerait bien parler français.
Si tu permets.
Est-ce que je peux poser une question?
Les modérateurs, si vous permettez, je viens de regarder un peu les participants.
Oui.
Il y a quand même pas mal de pays arabes qui suivent. Et malheureusement, ils ne vont rien comprendre si on parle français. Donc,
exactement.
On va faire l'effort de continuer en anglais, si vous le permettez, je pense. Hein.
Okay, we will continue in English. Thank you very much.
Yes.
Isabelle,
Continue in English.
And I want, before to ask or to, I want that first you answer the question about the presentation, the case of Mona. What do you think here, Isabelle?
So it's a challenging case, right? So this is a case that clearly is not a de novo high-grade glioma. It is a case that was there because we have the MRI showing that the lesion was actually there and then continued to expand. The first question that I always have is, how are we really sure that the histology is the correct diagnosis? And that is always very challenging because the neuropathologist can only tell you what they see. And if the specimen received is small, sometimes it's confusing. And as I said, with the 2016 classification, now the histological appearance to the microscope to the eyes is not the only factor. And so if IDH and ATRX and 1P19Q were not assessed, it would be important to reassess those on the specimen. So what I'm trying to say is that sometimes we cannot go back in time, but we can pause and reassess. So if that specimen is still available, I think that it will be good to understand with the new genetic signature whether or not it's really true that that is an anaplastic ependymoma. With that said, at the present time, I think that going back in to obtain new tissue so that that can be also reassessed and drain the cyst might, and I say might, give some opportunity for additional therapeutic options. And so at my institution, we would proceed with that.
Okay, so which kind of additional therapy? Because he already had radiotherapy, stereotactic radiotherapy, and temodal. So
right. So for instance, if that tissue was positive for PDL1, we could start him on nivolumab, which is immune therapy. The other possibility is whether or not the patient, so you said that it's clear that it's recurrence. I'm not sure that it's clear. It could also be tumor treatment related effect. In fact, I think that there is a very good chance that that is it. And so if it is pseudo progression, then you could help the patient possibly with Avastin just by reducing the amount of swelling. So those are the two things that come to mind.
Thank you. Thank you very much.
Great case, and thank you for your presentation.
Thank you.
Who wants to give his opinion?
Professor Al-Khamlishi want to ask question? Professor Al-Khamlishi want to ask question?
Yes, Professor.
Professor Al-Khamlishi.
You hear me?
Yes.
Yes, we do, Professor.
Good afternoon and good morning, because we are in different times.
Good morning, good evening. It depends on the time.
Thank you for the organizers of this nice webinar. And of course, thank you to Isabelle for your excellent presentation. And how we are happy to hear, of course, and to see you and to and to be sure that everything is going well in New York in this difficult period. Now, I have one comment and two questions. The comment is regarding all the cases you have shown us. Maybe I didn't follow your slides, but I didn't see what was the histology. All of them were high-grade glioma, because I think that this gross total resection, helped by all this location and technology pre and perioperatively, is excellent, and of course with very good results in the low-grade glioma. In high-grade glioma, have you any difference in the results using these techniques, and how many cases are seen at very soon? I mean, with quite located tumor, and of course which were a malignant glioma. And the second question is, what do you think regarding the high functional area as defined since many years, and the cerebral plasticity, which is now progressing, and especially again in a low-grade glioma, and maybe in some benign lesions secondary to which give just epilepsy, that this functional location is displaced with the chronic evolution of the lesion, and that we should have some quite not so tight definition of the high functional area when we try to remove these lesions. What do you think about that? And thank you again for your presentation.
Thank you very much for your kind words. I think that when I mentioned the word cure with a gross total resection, you're absolutely correct. The low-grade gliomas are often cured by a gross total resection.
Yeah.
I did mention, maybe too fast, that for the high-grade gliomas, the word cure is only seldomly applicable. However, that if we perform gross total resection for high-grade gliomas, the longevity, the survival is significantly improved. And yes, every single one of my cases were high-grade gliomas, and the literature now is really abundant, showing that there is a statistically improved survival for patients with high-grade glioma when there is a gross total resection, provided that we do not induce a neurological deficit. If we induce a neurological deficit, that patient goes into the category of a biopsy patient, meaning that his or her survival is not going to be as high as the other group. But absolutely, extent of resection is associated with longer life for high-grade glioma patients.
Okay. I think
Let me collect.
Hi. Okay, thank you, Dr. Bouzouba. Thank you, Youssef. I don't see Isabelle.
Hi.
Hi, Isabelle. How are you? Well, very great presentation, and thank you very much for this presentation, because it's really very important to know what to do to the glioblastoma. So my question is, did you make study about 5-ALA and MRI, intraoperative MRI, and to see what is the efficiency of 5-ALA? Some neurosurgeons do that, and they find that only when in 5-ALA his total gross removal, but when he make MRI, intraoperative MRI, he sees that there is small pieces of tumor again. What do you think? Did you make this study, or what is your advice? Is 5 ALA is sufficient, or it's not sufficient? So MRI, intraoperative or scan, intraoperative scan is important to complete the gross complete removal. You understand my question?
Of course, very well. Thank you. It's a very important question. So it's a very easy answer. As I mentioned, we do not have an intraoperative MRI at Mount Sinai, and therefore I cannot answer your question. I don't rely on 5-ALA for my resections. I rely on the intraoperative navigation, and I rely on updates of images with the ultrasound. Now, this is for those tumors that are echogenic. So what that means is that it's going to be for the high grade, for the glioblastoma, which is highly echogenic. Your question is very interesting, especially for those low grade tumors. However, the low grade tumors do not fluoresce. By and large, they do not fluoresce with the 5-ALA. So I think that there is much more to come. I was part of an NIH study session for 2 days on Monday and Friday, and we reviewed grants for 8 hours each day. And I can tell you that there are many promising techniques that are coming about to really help neurosurgeons in differentiating that normal tissue versus infiltrative margins for tumors that do not fluoresce and for those tumors that do not have an echogeneity. So maybe next year we can talk about it some more. Today I can't because it's all considered private information.
Thank you, Isabelle. Thank you very much. It was great presentation. Thank you.
Professor Bouyoussef has a question to ask a question.
Professor,
and after, if you agree, I have many questions about. I collect written question. I will ask you this one, Professor Bouyoussef. We don't
hear you.
We don't hear you.
Micro, des micros.
Micro.
Oui.
Voilà.
C'est bon là?
Oui, oui.
Yes.
Thank you. Thank you for this very complete conference about high-grade gliomas. If I agree with you, when the tumor is low-grade, we have to be very aggressive. I agree, 100%. But in high-grade gliomas, the benefits of total gross total removal is in terms of weeks, very months only. When we don't have all the tools we have, you have intraoperative monitoring, intraoperative MRI monitoring, etc. I don't know if the benefits is very good for the patient. Even if you do a total gross removal, when you leave your operative field wide, 2 months later, all the hemisphere is invaded by the tumor. That is why I think that for high grade, certain cas seulement, if the tumor has necrosis or hemorrhage or cystic, and we have to, we are afraid from the engagement, at this moment we can perform surgery, invasive surgery. But for those low grade, I agree with you. Je ne sais pas si je me suis bien exprimé.
Oui, c'est très clair. Yes, it's an interesting perspective, but the landscape is changing because now we have a better understanding of the molecular signature of glioblastomas. Not all glioblastomas are the same. So it's been published in the literature multiple times by multiple authors, and it's also our clinical experience that for those patients that, for instance, are MGMT methylated, their survival is 25% of those survive more than 2 years and longer. So it is not longer the case that everybody who has a glioblastoma will recur within 2 months. And we have now a growing percentage of patients that survives 2, 3, 5 years. And in my practice, I have some that have survived past the 5 years. And this to me is very, very rewarding. And I think it's only possible if you're very aggressive with your first resection up front. And then if you give them the therapy that their molecular signature requires, not just the generic treatment. And the more we understand about that genetic signature, molecular signature, the more we will be more productive with our energy, in the sense that we're not going to waste money to give therapy to patients that will not respond.
Thank you. Liba, I agree with you.
Yes.
And we
I have many questions.
Prof. Liba?
Yes, I'm here. I collect the written question by awareness or by awareness.
May I have a question, please? Is it
Prof.
possible?
Liba?
I'm here.
I already checked my hand.
I'm here. Nadia, you have a question?
Oh, yes, I have a question and comment, if it's possible.
Okay.
But, you can go to the question of this of the audience as you want. Huh?
Yes.
May I can? So just for
you ask
I would like to
you ask your question, Nadia. Yes.
Thank you, Suhail. And I would like to thank, of course, on behalf of Moroccan, Arab, and Maghrebian neurosurgeon, our guest speaker. She is, as all of you know, that she's one beyond of. She was, of course, the chairman of the Education and Training Committee of WFNS, but she is one of the masters in these fields, especially about high grade glioma. And my comment, we know that in our fields, in our specialty, we know all of us that the glioblastoma GBM is one of the baddest prognosis of glioblastoma specialty. And according to the cases that Muna presented in the first, I would like to have your opinion, my dear and excellent friend Isabelle. This is our dilemma on every day about these tumors, and we know all of us that it's a frequent tumor and frequent situation. What we start to do? Well, we have to operate them. We have to send them to radiosurgery because they already have radiotherapy and target chemotherapy. Waiting, of course, in the future, of course, what happen in the future, and it means that it's what target therapy, immunotherapy, or etc. We are hoping, all of us, that we will have in the future. We are, as neurosurgeon, technically, surgically speaking, we are, of course, limited in these special tumors. So, according to the case that Muna, of course, show us, what your advice? Give radiosurgery on this in these cases. Again, come back to surgery. Especially, in my opinion, I am really very against, but we need your advice. Thank you, Isabelle, again for your contribution.
Yeah, so I think I answered that. I think for this particular patient, it would be good to obtain additional tissue, because by so doing, you have the opportunity to drain the cysts and also to make a differential diagnosis between progression and tumor progression. If it is pseudo progression, there are different treatments than if it is tumor progression. And if you get sufficient specimens, you can maybe have some targeted therapy that can be given.
Dr. Tliba?
Professor Wahabi?
I raise my hand, Dr. Tliba. Can I have a question? Suhail?
Yes, yes.
Allez-y, Professor Wahabi.
Okay, thank you. Thank you. Thank you very much, Isabelle. Thank you for your nice presentation, and we'll be always happy to welcome you again in Tangier, not electrocally, but physically in Chair El Nos next time. I really, it's a fantastic talk, because you, this is a comment. I have a question. My comment is it is a well-balanced conference to manage a very frustrating case of pathology, tumor disease like glioblastoma is frustrating and dissolving. But I think through the use of multimodal approach is for very important goal, you said, it's for quality of life. But during all this procedure, you try to remove as much as possible, of course, and also it gave you the opportunity to understand more the physiology, how the brain is working. And you rose many very important issues. The correlation between functional MRI and the operative stimulation. It's 20% of patients we can't really predict what is the functional area. Also, the use of ultrasonography, the use of electrocorticography. So there are many tools you are using, but still you are being very wise in that you are doing what is reasonable. So it is very important for us with the limited resources, but still the use of awake surgery, I think, is one of the techniques that can be used even in developed country, most particularly to have to reduce the postoperative complication and the quality of life. So I totally agree with that point. My question is, do you have the same management protocol in case of recurrence? Because this is one of the, let's say, the things that sometimes we have to discuss. How you to go back for surgery or just rely on chemotherapy, radiosurgery? What is your policy? Thank you.
So this is great. Thank you very much for your nice comments and for introducing a very important topic, and that is the importance of understanding what to do for recurrent glioblastoma. So we just finished writing the update to the guidelines for recurrent glioblastoma that are now in a draft format, and hopefully they will be published toward the end of the year. The bottom line is that there is evidence that has been accruing over the past 4 or 5 years that a second operation for patients with glioblastoma might be beneficial. And in my practice, I always look at different factors, including the Karnofsky score. So for a patient that has a Karnofsky of 70 or more, so a patient that is still functioning independently, I think that there is benefit for re-resection. And that is compiled to the fact that by obtaining new tissue, you might have more information about that genetics and the molecular signature of the tumor. So more to come. Maybe in the next time we can talk about recurrence and how to differentiate between pseudoprogression, progression, and what are really the, what is new. I was in charge to write the chapter on chemotherapy and also on the other therapy. And I can tell you that there is a lot of very interesting stuff. So yes, let's try to do that sometime in the fall.
Okay, thank you.
Okay, Aïd Ben Ali, Professor Aïd Ben Ali, and after Professor Lakhdar.
Hello, everybody. Thank you very much, Professor Germano, for this very nice presentation. My question is answered yet. Thank you. It was about recurrences. Thank you.
Okay, Professor Lakhdar. And after Professor Brahim.
Thank you.
Nobody, I have a question for Isabelle.
Thank you. Yes, I have a question. Thank you for Isabelle for your excellent presentation. I have a question. Do you have some experience about the use of hyperbar oxygenotherapy in high-grade glioblastoma, or some papers, some research in oxygen therapy about glioblastoma? If you have some information. Thank you.
Unfortunately not. Unfortunately, I don't have any personal experience. Does anybody in the audience has any experience with that?
Question is open.
Hello?
Some participant.
Does anybody else have experience? I don't have any direct experience.
Sorry.
No, thank you.
Can you repeat the questions? Sorry.
My question is,
can you repeat the question?
Yes.
Sorry, because we can.
My question, yes, is the following. If someone has more information about the use of hyperbar oxygenotherapy in management of high-grade glioblastoma, some paper or some information about the research about this.
But I know that you have some information about that. I know in your hospital and your department, you try this this technique. So you can give us your opinion first.
I have not some scientific information. I have just a question.
I have a question for Isabelle. With the new classification, WHO classification, if that has changed some strategy, your strategy, especially after when it's important to consider ADH mutant, ADH wild type in the classification.
Yes, so I think knowing the genetic information, the molecular signature is very important, because although upfront all glioblastomas will receive radiation treatment and temozolomide, then when and if there is a failure, that information can be used to target the subsequent treatment. Also, it is important because if there are clinical trials, the patient can be enrolled in the correct clinical trial as opposed to just a generic patient with glioblastoma. So yes, has been very helpful to gain more understanding of the patient-specific tumor.
Okay, Isabelle, I have many questions by participants in awareness. The first one is, do you perform awake surgery for high-grade glioblastoma? And second one, what's your stimulation protocol for subcortical mapping? And what's your opinion about immunotherapy and brachytherapy? And about gliadel, the use of gliadel in glioblastoma.
Oh, very important questions. I think in the interest of time, because we're already running over. So for high-grade glioma, do I use awake surgery only if and when it's necessary, only if and when the tumor is really highly infiltrative, so it's not a de novo tumor. With a de novo tumor, it's unlikely that it's so infiltrative, so it's unlikely that it's going to be necessary. I would refer you back to that picture that I showed from Dr. Berger's paper showing one that was infiltrated, one that was not infiltrated. Second question was about immune therapy. Immune therapy at the present time has not been shown to be to provide benefits to patients with high-grade gliomas. However, there are clinical trials that are still ongoing, and it seems that a combination of multiple things, including immune therapy, might be beneficial. And again, when we speak about, when we will have another seminar in the fall, in November, whatever, we will talk about recurrency this time, and it's going to be very interesting to see everything that can be done with that. Gliadel, it's interesting that there was one phase 3 trial that showed, one paper with phase 3 trial all the way back in the 90s that showed that it is good to use Gliadel for a patient with glioblastoma. And sure enough, now that there is the SUPER protocol, which is radiation with temozolomide, that evidence is no longer there. So are neurosurgeons still using it? I guess you can use it, but there is really no abundance of evidence that is improving longevity. And in fact, there is evidence that is not improving quality of life because those patients had more complications than those that did not have the Gliadel. And I think there was one more question that you asked, or I'm reading it, about the temozolomide, whether or not you need to use it for 6 months or longer than 6 months. That is still a matter of debate, right? In some countries, like in Canada, it's only approved for 6 months. In my practice, we tend to use it for longer. And hopefully, if we put all the data together of all the countries, we might have a better understanding of what the time required is. But at the present time, you could do whatever you think is good in your practice because there are no guidelines for that.
Okay. And the management of net tumor with Caesar, as many people.
I'm sorry, I did not understand that.
It's question for Noor. Can you ask your question, Noor? Directly?
Oh, I see that, the DNet. Would you do, well, you know, it's always important to have that tissue diagnosis. And so if you radiographically, if you suspect that there's a DNet, again, I would be in favor of obtaining tissue just to confirm that that is correct. I think that if you want to wait and see if there is an increase in size, is also a reasonable option. So you have both options to you.
Okay, Professor Bakhti, you want to ask a question?
Thank you again, Isabelle, for your wonderful presentation. I had a question and a comment. First, the comment in Algeria, now pathologists can give us information regarding EDH1 or EDH2, which can give us an idea on prognosis. We have also ATRX, but unfortunately, we don't have MGMT, for example. So till now, we are giving a standard scheme with surgery, maximal resection, and of course, the scheme of Stoop. This is what we can do with the current, what is available in Algeria. And I want to ask for about TTF. Do you give, in the United States, do you give TTF as adjunct therapy for all glioblastoma or for certain types of glioblastoma?
So just to make a comment about the fact that you don't have MGMT testing available, I think that in our practice, the MGMT testing is irrelevant in the sense that all patients are started on Stoop protocol, even if there are MGMT not methylated. So it doesn't really matter. It does matter later if and when they recur to then address their best treatment option. The other question was TTF, which is tumor treating fields. And in my country, it is FDA approved for new glioblastoma, newly diagnosed glioblastoma and recurrent glioblastoma. The therapy is discussed with the patient, and it is given as an opportunity. Unfortunately, in my country, a lot of the insurances are not covering the cost, and that is a big obstacle.
But excuse me, it doesn't depend on the molecular profile of the tumor. We can give it for all glioblastoma. Okay.
Yeah. So I went fast because we were running out of time. But I don't know if this is recorded. But if you go back And if you look at that slide with all those metabolic pathways, right? There is one at the center that does say the DNA, and there is a big funnel going down saying TTF. And so, yeah, so what that means is that it's really not interfering with any of those pathways that might be different from one molecular signature and the other, but it's really efficacious, as far as we can tell, to all glioblastoma, because the way in which the TTF works is by interfering with the anaphase phase of the mitotic cycle, and therefore those microtubules cannot align, and therefore the cell does not divide. And so the mitotic pathway is the same regardless of the molecular signature.
Thank you.
I have a very interesting question from Coulibaly. Is it worth to operate high-grade glioma tumor in areas without additional radiotherapy or chemotherapy? I think many persons can answer this question.
Yeah.
What do you think, Isabelle?
So I think that the high-grade gliomas, particularly the glioblastoma, comes right back, recurs right back within weeks of the surgery without the STUP protocol. And so if you don't have radiation and if you don't have temozolomide, it's difficult to really show a benefit. And I think that would be an interesting question to answer, if those countries where this is not available, if they could put the data together and just see what happens to those patients if you operate. My prediction is that unfortunately, the vast majority will recur in a very limited number of weeks. I only, in my career, only once had a patient that did not receive any adjuvant treatment because he wanted to try holistic treatment. And that patient was back in my operating room within 6 weeks with a tumor that was just about the same size.
May I ask Saad to answer this question?
Yeah, merci, Youssef. Do you hear me?
Yes, yes.
Huh?
Yes, yes.
I think that this question from Coulibaly is very important in African context and in many regions, and this is also important to stress that the great effort in surgery of glioma should be dedicated and oriented to the low-grade gliomas, because this is the type of tumors, the group of tumors where the surgery, the gross total resection is efficient, and we can cure many patients who at least maybe have more than 70 to 80% for 10, 15 years survival. So if we don't want to arrive to this stage of glioblastoma and arise such question, should we operate or non-operate, we have try to make earlier diagnosis of the low-grade glioma, and never after having seen an image on CT scan or on MRI that it's maybe a lesion that could be a low-grade glioma, and never say, wait and see, the observation, which was something done in 15 or 20 years ago in many places, and maybe today also in our regions. So I think that my answer to Coulibaly is to tell him, please pay attention to the diagnosis of low-grade glioma and try to operate them or to make them operated with gross total resection. Now, when you have the recurrence, as the case which was shown at the beginning by Muna, for me, there is no place for second or third surgery, except if you have just to puncture a cyst by stereotaxic way, as was also advised by Isabelle, or maybe to check if you are not sure and you have not done all necessary pathology at the first surgery, but the second surgery and third surgery in glioblastoma, I think, has shown to many people that the benefit is very, very low, maybe some weeks, some months, and which are in general balanced by more complications.
I have to apologize, and I have to leave because I'm on call today, and I have the residents calling me from the hospital.
Okay.
So this was a great 1 hour and 40-minute webinar that we have. I want to thank again all the organizers. It's a pleasure being among friends, and I hope we can do it again maybe soon in the next 5 months or so. And I look forward to seeing you all again. Thank you.
Thank you.
Thank
Professor
you.
Lakhdar, maybe he will say a word to conclude the session. Professor Lakhdar.
Thank you, Professor Germano, for sharing your wide and extensive experience in this field with all this audience. And thank you, Professor Parti, the chairman of the WIN committee in WFNS, Professor Bouzouga and Kleba for Educational Committee for the animation of the discussion, and Dr. Muna Bougrine and Dr. Khawi for technical support, and also Professor El Abadi for your collaboration. Thank you for all the audience, and to the next webinar. Thank you.
Thank you very much. Bye-bye.
Thank you. Thank you,
Okay,
Isabelle,
bye-bye.
for your outstanding and your attendance, and hope see you soon in personally, because virtually is sure that is great, but we need to see each us personally. Thank you, and have a good day.
Bye-bye.
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 Vous, Suède?
Oui. Ça va?
Bravo, c'était une très belle session. Je vous félicite tous.
C'est sympa.